Hi, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly Brunch and Learn webinar series. My name is Liz Lowell, and I am the Project Manager Consultant. I am joined today by my colleague, Ashley Johnson. Before I introduce today's speakers, I would like to provide some background information and go over housekeeping items. So for those of you who are not familiar with us, NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, the AETCs. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care, and treatment and medical management for people at risk for and living with HIV. NAHUD collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, also known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. So we invite you to visit the ORN website for more information and or to submit a request for technical assistance. In terms of for accreditation for today's session, we are offering CME nursing and social work credits at 1.5 units, and we do have a certificate of attendance. In order to receive your credit, we ask that you please go ahead and complete the post-evaluation survey, the link will be included in the chat towards the end. You will also get a follow-up email for participating that includes that link. Even if you're not seeking credits or certificate attendance, we welcome you. We ask that you go ahead and complete the survey. We appreciate your feedback. We do share that with our speakers after the session and also use that information in terms of needs for different topics as we plan our next sessions. So as I mentioned, you will, once you complete the survey, give us about 2 to 3 weeks to send you your certificate. You may feel free to reach out to ask me any questions, but we will get it to you in about 2 to 3 weeks after today's session. We ask that you complete the survey. You have 2 weeks to complete the survey. So in terms of other logistics for today, I just share that we do have the webinar chat, and we just ask that you go ahead and use that chat to engage with your other speakers, other participants. If you have not entered the information like your name and your organization, as well as your favorite activity, summer activity, we go ahead and invite you to go ahead and use that chat. I would now like to introduce our speakers and just some background information on them. To start, Dr. Thomas Stopka is an epidemiologist and associate professor with the Department of Public Health and Community Medicine at the Tufts University School of Medicine. Dr. Stopka's current research focuses on the intersection of substance use disorder, opioid overdose, and infectious diseases. He employs geographic information systems, spatial epidemiological, qualitative, and biostatistical approaches in multi-site interdisciplinary studies and public health interventions to better understand and curb opioid-related morbidity and mortality. He currently leads and contributes to clinical trials and observational studies funded by the NIH, CDC, and SEMTA to test new HIV treatment and harm reduction models, predict and reduce opioid overdose deaths, and evaluate the overdose prevention impacts of administration of medication for opioid use disorder in corrections facilities. Dr. Stopka is also co-chair of the Tufts Research Priority Group focused on equity in health, wealth, and civic engagement. He teaches courses in GIS and spatial epidemiology research methods for public health and epidemiology. He enjoys mentoring research assistants, graduate students, postdoctoral fellows, and junior faculty. Also, Dr. Shika Shrestha is an assistant professor with the Department of Public Health and Community Medicine at the Tufts University of Medicine. His research involves the use of spatial epidemiologic methods to examine the socioeconomic factors associated with opioid use disorder and health outcomes. Dr. Shrestha's research projects aim to efficiently detect adverse events related to the opioid epidemic, such as opioid overdose and injection drug use related infectious diseases by utilizing qualitative, quantitative, geospatial methods, which can then be used for disease forecasting and planning harm reductions initiatives. He is currently a co-PI on a research study which aims to reduce the time to detect opioid overdose spike by 50% and improve the dissemination of alert to all the opioid stakeholders in Lowell, Massachusetts. Dr. Streschels co-chairs the Substance Use and Mental Health Disorder Research Subgroup in the Tufts Research Priority Group focused on equity in health, wealth, and civic engagement. He is also a course instructor for geographic information system and data wrangling methods in the health informatics and analytics program at Tufts University School of Medicine. And finally, Mr. John Kelly is the Director of Operations, Communications, and IT for Trinity EMS, a division of Pride Star EMS Incorporated. John and his co-workers provide 911 coverage for 13 communities in 2 states. John leads the only ACE accredited dispatch center in Massachusetts and one of 213 in the world. He leads the Trinity EMS data assistance efforts. This data is used by public health and public safety. He also helps EMS and public health agencies across the county implement EMS data assisted programs. So with all that said, I am very excited to go ahead and pass it over to today's speakers, beginning with Dr. Sapka.
Thank you very much, Liz. Really appreciate it. We appreciate the opportunity to be here. We're very excited to present to you all. It's been great to see that we've got representation from all across the country: California, Indiana, Colorado, Massachusetts, and Puerto Rico. Muy buenas tardes. It's great to really have the chance to talk with all of you. Hopefully share a project that's of interest to you, or several different collaborative initiatives that we've been working on together over the past several years. And we look forward to saving time for questions and answers at the end. Let me just do a double check. Can you see my slides in presentation mode? Sheeker's shaking his head. Okay, very good. So we're going to focus on a talk that highlights our efforts to improve public health responses through partnership, and talk about our unique collaboration to combat the opioid crisis and related morbidity and mortality in Lowell, Massachusetts. Great to see some folks not too far away here in Massachusetts, in Dedham and in Worcester. So we do not have any relationships to disclose. And the overall objectives of this presentation are to describe a partnership model aimed at decreasing the impacts of the opioid crisis, to discuss collaborative efforts that have aimed to enhance harm reduction services and reduce opioid-related morbidity and mortality in Lowell, Massachusetts, and to share evaluation and research findings from our collaborative work. So we'll start by talking a bit about the opioid crisis in Lowell, in northeastern Massachusetts, and Lowell Peers, which is a prior project we worked on together. John and I worked on together with other folks. It was the Lowell Peer Education and Risk Reduction collaboration project. And it was the beginning of really our unique academic public health and EMS work together. And we'll present a unique mix of data that highlights some of our geospatial analyses, GIS descriptive mapping, risk mapping, heat mapping, and hotspot cluster analysis, as well as EMS related touch points. And we'll talk a bit about some of our newer collaborative work and ongoing collaborative efforts to combat the opioid crisis, namely with a focus on our Stop OD Lowell study and the predicting opioid overdose efforts to predict future spikes for preemptive public health responses. So to set the stage, many of you have experience in this area, so I'll just briefly go over this, but we've still see over 100,000 overdoses during recent years, and the COVID pandemic didn't help the situation and perhaps exacerbated the situation. We've seen up to 30% increase over the prior year, and 70% of overdoses being opioid related. In Massachusetts, where we're situated, overdose deaths have quintupled over the past 2 decades. And there's more than 2,000 newly reported hepatitis C infections among young folks, 15 to 29-year-olds in Massachusetts during recent years. Lowell is within the Merrimack Valley, and through our work and through other work, has been identified as a hepatitis C virus and an HIV hotspot, as well as an overdose hotspot. And we'll talk a bit about an HIV outbreak that has happened here in recent years amongst people who inject drugs. So we'll talk quickly about the three waves that we talked about for a while, and the fourth wave that is more recent. But the first wave of the opioid overdose crisis, the current opioid overdose crisis, began with the rise in prescription opioid overdose deaths starting in 1999 and up to about 2009. In 2010, you see the blue line, where we saw a rise in heroin-related overdose deaths. As prescription opioids were recognized as a contributor to risk, the prescriptions started to decrease or level off, and the number of pain medicines that were prescribed or opioids that were prescribed started to level off a bit. But folks who are in the throes of addiction don't want to experience withdrawals. That's one of the most painful experiences one could experience. Imagine the worst flu, the worst intestinal bug, and more all combined. And so a lot of folks transitioned to heroin use, and overdose deaths related to heroin started to rise in 2010. Then fentanyl and synthetic opioids came on the scene around 2014, 2015. And that's where in that purple line, we saw the precipitous rise in fatal overdoses, largely related to fentanyl. The fourth phase, excuse me, which we're experiencing now, is really tied to stimulants and overlap with fentanyl appearing in stimulants, whether purposefully or accidentally, and folks who are opioid naive being exposed to a highly potent opioid that they perhaps weren't expecting. In Massachusetts, from the past decade, we've seen an increase. These maps, I'll show you a series of maps, portray overdose rates per 100,000 population at the zip code level. And going from 2011 to 2012, to 13, 14, 15, you see that more and more zip codes in Massachusetts are bright red, meaning that their rates were greater than 15.4 per 100,000, and in many communities, upwards of 25, 30%, or 30 overdoses per 100,000 population. That's above the state average and the national average. Overdose becoming ubiquitous. And with that, other risks, right? If we talk about the overlapping epidemics, or some folks would talk about a syndemic, that includes overdose, it includes hepatitis C infections, right, that are largely attributed to injection drug use. HIV risk with clusters appearing across the country. Some of our prior work, and one of my first students here at Tufts, helped to map mortality related to hepatitis C and HIV. And these red highlights on this map are statistically significant clusters of hepatitis C deaths.
So one of the first ways we got involved was in January of 2015. Lowell the city came to us and said, we need some help. You know, the opioid crisis is really escalating. What does EMS have? And what we were able to do is figure out a way through our patient care reports to figure out a way to extract that information, figure out which calls were potentially opiate related. Then we could go read the patient care reports. And we did that for about 2 years. We found in November of 2015 was the worst month we had ever had. There were a lot of deaths, and there was a lot of patients that needed to be saved with Narcan. And then in December, right, we always did the report after. December, we said, hey, that was really bad in November. And it was kind of like we as a community got together and we said, well, this isn't really helpful that a month ago we had all these people dying. How do we do that faster? How do we cut that down from, you know, our reports were always at least 30 days behind. So we associated with this company called First Watch. If anybody out there uses it, they live monitor our patient care reports. And that's, you know, this screen, we're looking at a surge of overdoses. So that's the backbone of our surge protocol, which, you know, we know, you know, an allotment of fentanyl today can be very different than an allotment of fentanyl tomorrow, right? That whatever dosage you use today, It could give you the effect you're looking for, and tomorrow that same amount might kill you. So the supply chain really can impact whether people live or die. So we started to use the EMS chart, patient care reports, to kind of give us a highlight, like, hey, these are happening now. So we could cut that window down. And that's what you're seeing here. We had if we had 20 overdoses in 72 hours, we had this kind of campaign out. We would send it out via media. We did press conferences. We would send it out on social media. We had a big email list, and we would try to send it out to the community like, hey, today is different than normal, right? We know you can't go check in your friend or your family every single day, but today isn't the day to skip. And that's kind of what this is all about. It's just kind of different slides about that. And later on in the presentation, towards the end, we're going to talk about the next evolution of that. And that's that stop OD that we'll talk about at the end. So if you want to change slides, please. So one of the things that we in EMS, and this is kind of I think, part of the unique collaboration, EMS doesn't really get involved in a lot of these, generally speaking, in public health. We do a big report every month. We've been doing it since 2015. So the database has about 15,000 overdoses in it, and each overdose has about 75 points of data. And we can do kind of all different presentations and information on it. EMS knows when the overdoses happened and where they happened. So what we found at the beginning of this journey, we found that our police reports, which is what we were using at the time, the city was using to identify overdoses, they only had about 50% of the overdoses that were occurring in the city. Law enforcement, a lot of times, either the patients don't necessarily tell the truth right away. They kind of keep information private because they're worried about being arrested, or law enforcement is tied up with scene safety issues. So really, that's how we got more and more involved. We know when the overdoses happened, right? Which is what you can see. You can see by day of the week. And then we know, the ebb and flow throughout the month of the overdoses. And then we know where the overdoses happen, right? So we can geographically, an overdose is much more likely to happen in our downtown area than our South Lowell, as an example. And then one of the other points we were able to kind of point out in early in 2022, we started to have a really big increase in our Latino population overdosing. It went from, they were a very low percentage of our patients up to 33%. And because we had access to that EMS information, we were able to show that most of those overdoses were happening outside, and they were happening in just 2 neighborhoods in the city. So we were able to kind of provide that information to the city, and they could focus a little bit, more specific instead of general approaches.
And so with all of this going on, right, with the increases in overdose deaths and with the monitoring that John was alluding to, with First Watch and with Trinity EMS having really solid data to help to monitor what's going on and put their finger on the pulse of opioid-related incidents. Lo and behold, there was also an HIV outbreak that occurred between 2015 and 2018. And they started to hit the press pretty heavily through the Huffington Post, through Locals newspapers and other sources. And the Massachusetts Department of Public Health, through their HIV surveillance data, where they'd been seeing decreases, right? Like many parts of the country, steady decreases in HIV-related infections amongst people who inject drugs over the prior decade, the early 2000s until 2014. All of a sudden, there was an inflection point, and there was an increase in the number of HIV diagnoses amongst people who inject drugs. Now, a few years prior, some of you remember Scott County, Indiana, had a cluster of HIV infections in a rural community among people who inject drugs. Now it was appearing to show up in Massachusetts as a concern, in the Merrimack Valley. And so this is the epidemiologic curve from MDPH and from the CDC. And you can see the purple curve, the cumulative number of cases over time. And then in those bars, the green and yellow bars, you can see the number of people who were infected and whether they were virally suppressed. Namely, have they been connected to HIV care and treatment? And were they receiving antiretroviral medications? You can see that the green represented a fair number of folks who were virally suppressed, so the risk for a forward transmission was reduced. But you see a lot of yellow in those bars too, right? So people who were not virally suppressed and who could, if they came into contact with and shared syringes with or had sex with somebody who was not infected, potentially infect other folks. So this was a major concern. And just to situate us, the Merrimack Valley is that northeastern Massachusetts location that's shaded a brighter red. And within that are the cities of Lowell and Lawrence. And the CDC conducted an epidemiologic investigation together with the Massachusetts Department of Public Health. This was one of several papers that came out of that. And they really found that the opioid epidemic, that fentanyl in particular, seemed to be fueling the HIV transmission amongst people who inject drugs in the cities of Lowell and Lawrence and in surrounding areas, right? Lowell and Lawrence are old mill towns, about 100,000 population, give or take. And when the mills shut down, there was a lot of economic depression in these towns. But HIV was on the decrease in the early 2000s, and in 2012 to 2014, the 3 or 4 years before this outbreak, there were only 41 newly diagnosed HIV cases in the Merrimack Valley. Now suddenly in 2015 to 2018, there were nearly 150 newly diagnosed HIV tests, people who tested positive for HIV. And they were primarily white men, young, between 20 and 39 years of age. And most of the HIV infections were tied to fentanyl, right? It has a shorter half-life. And so people need to inject more frequently in order to avoid withdrawals and feeling sick from withdrawals. And with that need to inject more frequently over the course of the day, there's more of a chance of reuse of syringes, more of a chance of sharing potentially contaminated syringes and transmitting viruses. Most of the folks who were infected with HIV also were testing positive for hepatitis C, right? Which is largely attributed to injection drug use. And amongst the people who were newly diagnosed, there was a high rate of homelessness as well. And if you look at this particular chart, you'll notice it's shaded in gray and in white. And the white cases were not linked to Lawrence and to Lowell. The gray cases were linked to Lawrence and to Lowell. And so you can see that in that 2014 to 2018 time span, the bars become more and more gray, meaning that HIV diagnoses were increasingly connected to injection drug use. And here, one other epidemiologic curve, you can see that the cumulative number of cases started to increase precipitously over time. And the gray bars here represent cases that were related to injection drug use. The bars are a bit wider here, right? The lighter shading here represent a larger proportion of these because now the CDC came into Massachusetts and they were able to help to do more advanced testing for HIV and network analyses to determine if people were directly infected through injection drug use or through peer networks. And this is what policy looked like during this time. And I'll just point out the red circle. That's when the privately funded syringe service program was opened that was related to our Lowell Peers project. So the public health response really ramped up once this epidemic, the spike in HIV cases became evident. There was an underground syringe service program in Lowell and Lawrence that was operating once a week or twice a week for a few hours. Through our Lowell Peers project, we were able to expand those services, and I'll talk about that more, and ultimately implement the first brick and mortar SSP. The CDC epidemiologic aid was really helpful in helping local public health officials to understand the HIV outbreak amongst people who inject drugs. Enhanced syringe service program access led to the flattening of the curve over time, as well as access to medications and additional preventive services. And the overdose education and naloxone distribution program expanded, right, to distribute naloxone to at the same time try to decrease risk for overdose. There's post-overdose outreach and then prevention and referral programs for people newly released from local jails who are at exceedingly high risk for overdose and viral infections. So Lowell Peers, again, was the Lowell Peer Education and Risk Reduction Services Program. And really our overall goals were to increase access to harm reduction and wraparound services, to train peer navigators, and to evaluate progress over time through surveys, through data that were collected through apps to monitor SSP and harm reduction efforts, and to map some of the local data to understand where the risk was greatest. We had a tremendous collaborative team with folks from the Tufts School of Medicine, including some of my former students and research assistants, including colleagues at UMass Lowell, the Life Connection Center, with whom we collaborate closely today. That's a place that provides free meals. During COVID, it was also a shelter, and that's where the brick and mortar syringe service program is situated. We worked with the Lowell SSP, this was a mobile SSP, as well as Trinity EMS as a key collaborator. So the targeted public health impact was to try to decrease syringe sharing, decrease syringes found in the community, decrease disease and overdose outcomes, and to enhance access to wraparound services. And the wraparound services included HIV, hepatitis C, and STI testing, increasing referrals to infectious disease prevention and care, including vaccinations and treatment, and increased referrals to drug treatment as well. And we also, in terms of syringe access, we're working with other harm reduction agencies in the area. So we're with the Lowell SSP, Lowell Peers, but then Health Innovations, which is a mobile van and clinic that hits a number of areas along the eastern portion of Massachusetts, and enhanced naloxone access. And these are some pictures of some of our staff who were working to provide access to sterile syringes and naloxone, and some of the trainings that were done with our staff through the Lowell Peers project. We did go out periodically with our team and with a larger cadre of community members who had interest in joining us to pick up discarded syringes in the local community. I think that's John on the lower right-hand side and me on the upper left-hand side. We tried to do this throughout the year, different seasons, right? During the winter is a bit tough because the snow covers a lot of the syringes.
Tom, that wasn't me. My shirt would have been tucked in.
Thank you.
I don't want to look like a slob. But one more thing about the naloxone. One of the kind of the unique things we came up with as a group sitting at the table was the QR codes. We put a QR scanner on each box. And then if anybody took a picture of that, like with your camera, it would bring you to YouTube. And there was a video from one of the members that was teaching Narcan to those individuals. So, when we left the Narcan behind, you could teach them real quick, but then we wanted to provide quick, easy access for them to, like, if they wanted a refresher. So we printed out a bunch of the little QR codes and then we put them on each of the boxes.
Thank you, John. Good points. And I should have known. It was one of your colleagues. So these were some of the trainings of our staff and peer leaders who were essential in moving forward with the overdose education and naloxone distribution. We enhanced mobile SSP services. Some was mobile out of the back of someone's car. We also really sought to build relationships with other community-based agencies to whom we could provide referrals and who could refer some of their clients to these services. We worked on getting sharps containers and FIP packs out to try to, again, decrease syringe discard in local communities and disseminate health promotion materials. And, the first brick and mortar SSP was one that we started at the Life Connection Center. Many of the indoor photos that you saw on the prior slides were at the Life Connection Center. And they began hosting SSP services 4 hours a week. And then that expanded to 8 hours a week. And then it expanded to 3 to 4 days a week, which greatly enhanced opportunities for folks to get access to supplies that could help to decrease transmission and provide opportunities for referrals. We started to enroll a good number of people in the project through the Lowell Community Health Center partnership to distribute a number of naloxone products, distribute naloxone refills, and provided access to various types of sterile supplies. And, you know, the local press and local public health officials started to pay a lot of attention to these programs because they knew that the needs were great. And ultimately, I put authorization in quotes because the SSPs, a court case took place in Massachusetts right around the time we began our project. And the court case determined that any individual, any organization can carry out syringe exchange anywhere in the state without having to get authorization. It was a ruling of the Supreme Judicial Court of Massachusetts. And so our timing was great in that now we had authorization and went through local approval processes through the local Board of Health in Lowell, and then through the Massachusetts Department of Public Health was able to now subsidize the program so that it could continue and be sustainable moving forward. Needed to get that type of approval in order to be subsidized from the Massachusetts Department of Public Health. We also worked through an advisory board and an advocacy body. We had a community advisory board. And when we initially were recruiting, we were trying to get folks from a number of different agencies, a number of different domains and areas of expertise, from harm reduction to public health to community-based agencies to home housing programs to law enforcement. And we did successfully recruit and work with quite a diverse mix of folks on our advisory board from a number of these different agencies, including John Kelly. And that's when we really started to work with John in earnest. This was probably around 2017, 2018 or thereabouts when the project started. So we evaluated our program. We value data to hopefully inform policy and decision-making and to better understand how our project is working, who we're reaching, and what types of services are we providing to them. So we quantitatively assess client demographics and SSP services provided. We qualitatively, through in-depth interviews and ethnographic observations of local neighborhoods, get a feel for the local risk landscape. And we did interviews with our peer participants. And through our mapping, we're able to better understand where opioid-related incidents are happening more often, where syringe discard is taking place, and where overdoses are more prevalent. And we used an app called EpiCollect 5 to help to map our syringe pickups. So when we went out in force with our group, we had group members download the app to their phone, and when they picked up a syringe, they could document what was picked up. The app would note the longitude and latitude of where it was, so that ultimately it could be mapped. And we can see where the circles started to get bigger, where there were more syringe pickups. And that's a proxy for risk, right? For injection drug-related risk for virus transmission, and also for overdose. These are some of the numbers from our project in terms of supplies distributed, client visits, syringes distributed. It was substantial, right? In the tens of thousands. And this is what's needed to start to bend the curve for HIV and hepatitis C transmission. Our clients, were folks who had experienced a lot of risks as it relates to overdose. Many had reported rescuing others using Narcan or naloxone. Some clients, a relatively high number of clients reported having HIV. And this was in the midst of that HIV outbreak amongst people who inject drugs. And many reported hepatitis C and a few hepatitis B viral infections. We worked with 30% of our clients who were female. We worked with some participants who reported or identified as another gender. And in general, the white clients were the largest population in the community, but Latinos or Latinx community members were the second largest population with whom we were working or who we were reaching. And for folks who know the Merrimack Valley, places like Lawrence and Lowell have very high portions of their community that are Latino or Hispanic. At the time, the most common drug of choice was heroin. This was when fentanyl was starting to enter the drug supply. So we were just starting to enter fentanyl on our surveys. But the lion's share, more than 3/4 of the participants were reliant on what they believed to be heroin at the time. And the second most common drug of choice amongst our participants was cocaine. Now, this peer network-oriented intervention we called RAP, the Risk Avoidance Program, we aimed to train peer leaders, folks who might be in the mix, like folks who might be struggling with addiction themselves, but who are practicing harm reduction and who could help to influence their peers to get, to better practice harm reduction and reduce the risks related to substance use and injection drug use. And we also were evaluating the work that they could do subsequent to the training. So the peer health advocates were trained to become key opinion leaders amongst peers, to develop strong liaisons with public health and public safety officials, and to provide referrals, and to help to disseminate prevention messages and materials to their peer networks. Now, through our efforts of going out and picking up discarded syringes, the Lowell Public Health Department was quite interested in this. And Trinity EMS had been really heavily involved in syringe pickups over time. And some of the data that I will share with you shortly really depended on Trinity EMS data. Ultimately, all of this work and the need for a systematic and regular syringe pickup led to the hiring of the creation of a new position for syringe collection program coordinator, and ultimately Andres Gonzalez was hired. John, did you want to say more about the role that Trinity EMS has played and continues to play in terms of syringe pickup?
Since at the very beginning of the opioid crisis, kind of ramping up all those years, there was a lot of needles in the community, syringes out in the community, parks, fields, bathrooms, and there was no real avenue to pick them up except us, right? It's not an EMS function. It's not really something that we as a provider for the city or contract with the city really is generally does, but there was no one else to do it. So we got heavily into that, and we were able to, every event we would log as a call. So we were able to, and Tom said, we'll get to it in a second, we were able to show quantitatively the increase, where the overdoses were happening. And then with Andres, we sent him through our orientation, and we were able to give him the bloodborne pathogen training and a proper, like the methodology to pick stuff up, how to dispose of them and that sort of thing.
Thank you, John. There's a question in the chat about Lowell peers and where can I get more information. So this is a paper that we published a couple of years ago. John, myself, and our collaborators at Lowell Department of Public Health and UMass Lowell. So I would encourage you to take a look at this paper. I'll share with you some of the findings from this, but you can learn a bit more about Lowell peers in this paper. The overall study goals for this paper were really to assess the spatial risk environment, the geospatial risk environment, to compare trends, spatial patterns and temporal trends in terms of syringe discard patterns, opioid-related incidents, and fatal overdoses, and to identify hotspots for injection-mediated risks across the city. So we worked with publicly discarded syringe reports, opioid-related incidents, and John will go into more details on these in a minute, and decedent data from local public health department and registry of vital records. We also access these through the state registry for vital records and statistics.
Yeah, as Tom said, so we were able to, because we had spent the decade or so creating patient care reports for every needle, we were able to go through and have 7 years of how many overdose or how many needles we found and where they were found. We were also, we'd gone back in time and read all our patient care reports. So we started in 2015 reading them specific for opioids. We went back in time and read all the way back to 2010 and did some modeling for the years before that. So we're able to kind of show a longer trend with that. And then for the death certificate part of stuff, me and the substance use director for the city, we spent 3 or 4 days in City Hall reading every single death certificate for 2015, 16, and 17. Document, noting if it had opiate or fentanyl or anything like that, and then writing the address down. And then we're able to compile all those things, and we'll show you that in a sec. I just described basically on this slide what I just talked about there. Yeah, so if you want to jump ahead there, Tom.
That's good, John. So the data that Trinity EMS collects and monitors has just been really valuable to the city. Like John mentioned earlier, he presents to city council, and there's a opioid task force that was going strong, particularly leading up to and in and around the HIV outbreak. And John often would provide snapshots of the data that could help to inform public health response and policy. Here in this paper, some of the GIS and spatial analyses included geocoding address level data for syringe discard reports and fatal overdoses. And then through the mapping, we presented and developed these risk maps that we'll show you, heat maps, and hotspot cluster analyses. And then ultimately, some additional analyses have looked at changes over time, right? Trends in aggregating opioid-related incident counts and syringe discard reports on a monthly level for an 11-year period. And this is what the trends look like. And what you see in gray, right, the gray shaded bars represent opioid-related incidents. And then John and his colleagues felt like, well, we should take a closer look at some of these, because sometimes maybe the way it's written up in reports amongst the EMS folks, there could be some false positives. John, did you want to talk about that a little bit?
Yeah, so the bigger sampling, what we would do is just use Excel, and we use conditional formatting. So we would, every interaction we have with the patient, we create a patient care report, right? There's a federal standard. So if anybody out there is thinking about that for their EMS agency, we don't really do anything unique. I think the one thing we have that is unique is access to it. But we would put the whole story from that call into Excel. We would use conditional formatting and look for keywords. So look for Narcan, opiate, opium, heroin, fentanyl, that sort of thing. And if any of those words were found, it would highlight them into that gray chart, right? But then we would read it and we'd be like, okay, if someone wrote, I don't know why they would do it, but if someone said no Narcan used, it would have been in the gray line, right? Because Narcan was found, but in the green, it was quantified. We would say, okay, that's not a real one. We would take that out. And what we found was about 76, 77% of the time that it was that Excel and First Watch would find this might be an overdose. It was. And that's and then the black line is the syringe pickups that we also had, right? So you can see as the green goes up, so does the black, right? It kind of mirrors itself, because what we're finding, as Tom said earlier, is we're finding more and more needles in the community, and that's indicative of more and more opiate related overdoses.
Yeah, and well, you might also notice a seasonal pattern, and where you see the dips, for instance, maybe more in the colder months. Often, when you see some of the peaks, often in the warmer months. For syringe pickups, that makes sense, because if there's snow, it's hard to find syringes. But what we were really impressed about with these data is how closely they align, the syringe pickup and opioid-related incidents. You know, we can call these data syndromic surveillance data. And these are, I won't go through all of the details in here, but this is a table from the paper as well. And we looked at all of the different neighborhoods in Lowell, and we looked at their population. If you look at the columns on the top, the overall population counts, opioid-related incidents, calculated a rate per 10,000, syringe discard reports, syringe discard rates, right? That allows us to normalize by population differences in neighborhoods, and then average annual fatal overdose counts and average annual fatal overdose rates. And this began to help us to highlight some neighborhoods, like the downtown neighborhood, the Centralville neighborhood, and the Lower Belvedere neighborhoods, where not the counts and the rates were particularly high, and that might merit, you know, an even more concentrated public health and clinical response.
And I think that's really where the key where EMS data comes in, right? Because we get the very geographic heavy information in our patient care reports that we're able to drill down to that level.
Yeah, well said. We did find this seasonal pattern, which I was alluding to with the overall temporal data over time. We did find that spring and summer generally were times when there were higher counts and rates for non-fatal opioid-related incidents compared to the fall and winter months especially. And this is an example of a hotspot cluster map where we had mapped the syringe discard data, and then we run an analysis within our geographic information system, and the red represents a statistically significant cluster, something that public health officials can hang their hat on. Like, these are the neighborhoods where syringe discard is most intense, and as well as other opioid-related outcomes. This is a composite density score, so we've combined fatal opioid overdose data, syringe discard data, and injury locations, opioid-related injuries. And it provides us with kind of a smooth surface of higher densities of these opioid-related outcomes. And again, this can help to inform where are harm reduction efforts most needed in the city of Lowell? Where are services or referrals to treatment, HIV testing, hepatitis C testing, medications for opioid use disorder perhaps most needed? We also, with one of my former research assistants, began to look at a vulnerability assessment where we weight and overlay these different layers of data on hepatitis C overdose, and then overlay on that the different services that are in close proximity to these areas of highest risk, to try to determine where are there gaps in services. So overall, opioid-related incidents and syringe discard trends parallel the opioid overdose trends. So this syndromic surveillance data can be quite valuable if you can gain access to it locally to better understand where there is higher and lower risk in your local communities. The systematic documentation, mapping, and spatial analysis of syringe discard could guide cleanup efforts, provide a helpful proxy for clustering of overdoses, opioid-related incidents, and injection-mediated risks, including HIV and hepatitis C. And our collaboration, we felt very happy about, proud about. You can hear John's expertise. He's in the communities regularly, has his finger on the pulse of what's happening as it relates to the opioid crisis and a whole host of other outcomes. Working with local public health officials was key also, because they're the policy makers. They're the ones that can implement public health responses and harm reduction efforts. And we hope that our part in terms of academic research helps to elucidate some of the challenges and identify some of the gaps where services are needed. Ultimately, our work, we evaluated the risk environment as it related to opioids, identified overlapping patterns in these outcomes, identified locations at highest risk, and the findings could help to inform public health interventions and responses. So I will turn it over to Shikhar at this point to talk about our current work.
Thank you, Tom. So The current project that we're working on in Lowell, Massachusetts is titled Syndromic Surveillance to Prevent Overdose in Lowell, Massachusetts, Data to Action and Evaluation. The study MPIs are me, Tom, and Jen Putz. And this was funded by the Foundation for Opioid Response Efforts. So let me get back to the statement that John had made a little bit earlier on during the presentation about reviewing the ORI reports, and when number of opioid-related incidents hits about 20 in a period of 72 hours, usually an alert is put out in different channels, sometimes or news, radio, or let's say Twitter, Facebook messaging, in different avenues to alert people about, let's say, increased risk. Maybe there's a bad batch going around, maybe something's happening that is causing an increase in opioid overdose. And the system works really well. I mean, it helps people to be aware of increased risk in the surroundings. It, maybe prompts people to check in on their loved ones if they think that they are at risk. And it is a good effort to reduce opioid-related incidents, and because it detects clustered exposures and tied to, in this case, fentanyl, and it facilitates communication. However, there are some limitations to the system. Right now, the system needs to detect about 20 cases in the period of 72 hours, and there's not a lot of systematic information dissemination system. There's no a formula, a protocol on, okay, if we detect X, Y, and Z, what are the things that we need to evaluate systematically, who or where the information needs to be transmitted to, and there's some lags that is associated with the reporting, which may prevent, some of the activities that are aimed towards protecting lives and, dispensing of naloxone and all of the other interventions. So we thought, okay, maybe we could use some more additional tools to improve upon the system that is already there. I think the team has done wonderful jobs, and we were thinking, how can we improve the things, the alert system? And our first objective was to improve the syndromic surveillance system in Lowell by reducing the ORI spike detection time to 50% by using a couple of different spatial epidemiologic methods. This is basically using some spatial statistics to develop this probabilistic method where we could detect, increase in opioid overdose before we actually have to see that many cases. And next, we also wanted to see, is the information being effectively communicated across different channels, and how in any information regarding, let's say, increased risk of opioid overdose is being communicated within the vulnerable populations themselves. So our overall objectives would help us inform our work with stakeholders and optimize communication channels by streamlining data to action flow, and then creating concrete response program and ensuring that alerts are transmitted directly to the most vulnerable community members as soon as possible. Next. So this is a couple of pictures from our earlier study planning visit. I think it was about 2022 March or something, right after we got funded for the study. We do a lot of our study recruitment at Life Connection Center in Lowell, Massachusetts. They have the mobile RV, which they use to reach out to a lot of different areas. And in the last photo, we have our team members along with John at the Owl, where we usually get lunch when we are in Lowell. And it's been a great team that we have worked with, and a lot of the folks at LCC have been really helpful in not just helping us understand what's going on in the city, but also helping us in recruitment of stakeholders as well as people who use drugs, so that we get a lot of detailed information on what's happening. So with a lot of the with the project, in the first objective, what we have done is that using the data collected from Trinity EMS and a lot of help from John, we have identified ORI cases and developed protocols to more specifically identify opioid-related incidents specific to opioid overdose. And as John had said earlier, there were some cases that would be related to, let's say, Narcan used or syringes, but maybe related to other cases such as, let's say, diabetes or insulin syringes. So we have develop additional algorithms to identify specific cases, and we are looking at trends of variation in different years, months, time, day, examining overall trends and spike in historical patterns, and and using that to forecast future outbreaks. And we are working under the hypothesis that if there are an increased number of overdoses in a short period of time that are also closer to each other, that has kind of a spatial and temporal relationship, they are much more likely to be related to each other. And therefore, we don't need to observe a large number of cases, let's say 20 number of cases in the 72 hours. Maybe we can detect 10 to 11 cases in the 36-hour period, and that would be as good of a metric to predict spikes in overdose that may happen, so that we can react to it much faster. Next. So we have been developing a couple of different methodologies, examining not just temporal patterns, but also spatial patterns. So this figure shows 3 different trend lines that examine 3 different types of areas. I think it's at a sensor tract level that shows, first one is diminishing hotspot, which we don't really see a lot of observations on that end. No pattern detected, which is basically the kind of what we see as a base level noise, and then persistent and sporadic hotspot data points, which when we look at the spikes, definitely tells us about where things have been increasing or decreasing, and gives us something to think about. Like at those points, more attention should be paid. Even among those incidents, we do a lot more detailed evaluation of the number of cases and identify spikes in opioid related incidents. And currently we are working on a dashboard that creates a visualization of opioid related cases, trend lines, and also a marker for increased risk, basically a marker that says, increased risk of opioid related spikes in the next 72 or 48 hours, depending upon how many cases that we have observed in the past 36 hours or so, thereby, allowing stakeholders and other, people involved to get more information as soon as possible. Next. And in addition to the quantitative work that we've been doing, we have also been doing a lot of qualitative and survey research. We not just want to develop a lot of statistical model to improve prediction, but we also want to know if that information is being shared properly, if people know about the opioid-related spike detection system that is currently in place, how they have used it, what do they think of it, what can be improved, what is the best way to reach out to people with the opioid-related spike alerts, and how do people react to the information provided to them. When we could, did the key informant interview with the stakeholder, we saw a couple of emerging themes, and one of the themes was related to drug patterns and trends. And in the more recent months, we've seen methamphetamine in the drug supply. And one of the quotes that we have put in says, I'd say over the last year and a half, we've seen like introduction of meth into as common drug use. Like there was always occasionally someone that would like, maybe that would be the thing, but it's being more and more prevalent now. And John, do you want to add a little bit to this?
Yeah, we've definitely seen a big uptick in meth. We're seeing a lot recently with the medication shortage, street Adderall. We're seeing a lot of people who are buying what they think is Adderall, and they're getting some combination of meths, maybe some fentanyl in there, but absolutely big increase in meth in the last maybe 6-10 months.
Again, in terms of, next. When we asked, our stakeholders about the current ORI alert system, we saw like a lot of respondents who said that there was some lack of knowledge of the formal ORI system. In addition, we asked them, okay, who gets these alerts and who misses these alerts? And one of the biggest themes that stood out was residential areas, or those people who lived alone, were not getting the alerts as much as possible. The alerts were more communicated with active use population, or people who were actively using the harm reduction centers or treatment programs, but not people who were living in the residential areas. One of the quotes was, but people behind the closed doors don't get the word as much, which we identified as high-risk population. And as for the communication methods, the stakeholders stated that there was no wrong way to spread messages, and that word of mouth is important. And also text messages, phone alerts like something like reverse 911 or Amber Alert could be an efficient way of communicating these alerts to the public. As for the key informant interviews with the people who use drugs and their ORI spike alert perspectives, there was a kind of a mixed feedback in terms of what people were doing with the information. There were a large group of people say that, okay, yeah, we would want to be careful when there's an increase in overdose going on and not want to, seek those out. But there was also a group of people who said maybe, we would seek where the drugs were coming from and, want to know where the people who overdose got the drugs from. So this also kind of highlights the way to frame our messaging regarding the alert properly. They also highlighted who were at increased risk of overdose. So a lot of people cited that individual with clean time who did not know what was out in the drug supply as who would be at highest risk because the dose varies day to day, and the things that are out right now could not have been the same in the past, when people were actively using. So because of such a variation in the strength of fentanyl and the potency of fentanyl, people with clean times were perceived to be at high risk. Next.
I'm just going to read this bottom quote because I think it's an important one. Everyone I heard overdosing is mostly not people who have using like every day. It's people who have like clean time or they went to jail and they want to use. And this really speaks to the fact that folks who perhaps, whether they go to treatment or whether they're incarcerated, their tolerance drops because their use drops. And then if they're released and they slip and they use again, particularly in a fentanyl prevalent drug supply, they can get hit really hard. And that's where overdose risk is exceedingly high. In Massachusetts, people who are recently released from jail are at something like 120 times increased odds of overdose during the couple of weeks post-release.
Thanks, Tom. And among other themes from people who use drugs regarding communication methods, and this has been highlighted many, many times, is that the word of mouth is important in communicating the messages. And this is from one of the respondents. They said, I've had dealers tell me, oh, people are overdosing on this stuff, but the needle exchange, sometimes they'll say, they will let you, and really word of mouth, that is the important way of communication. A lot of other communication methods were such as flyers and text and emails were also touted as a good way to reach to people. There has been some issues with reaching people with text because the frequency in which they change phones is pretty quick. Usually every 2 or 3 months, they get new phones and new cell phone numbers, but we have been exploring other ways or apps. I think there's been talk of a new app that people use consistently so that even if their phone number changes, the app can help them retain their communications, phone numbers, and networks. And possibly using those channels would be an efficient way to put out alerts. We also interviewed about 100 people, people who use drugs from LCC to get a much more quantitative information on knowledge of ORI alerts and how they have, what they've used in the past. So next. So among the population sample, and I think this was based upon about 60 to 70 people when this presentation was made, about 41% had received or heard of an official overdose alert. Among those, most of them were told by someone else. So even if it was an official overdose alert, it was communicated through word of mouth. Approximately, actually more than 70 to 80% thought that the alert was useful for the most part in knowing about the increased risk in opioid overdose. And finally, this fourth one, about 40% people said that they did not receive the alert on time. So which means that maybe potentially a lot of work can be done. And almost 70% of the people say that it would be helpful to receive the alert a little earlier, because a lot of times unofficial communication or peer network communication among people who use drugs have been much more fast in communicating where or how many opioid-related overdoses are happening in the recent months. And among this, from the baseline survey, we see that a lot of participants think that text messages would be the best way to receive the alert. Second would be social media. And a lot of people use Facebook, so about 65% or so. So potentially we are planning on exploring a combination of text messaging and social media to put out ORI alerts when we develop a fully fledged protocol on, putting out the ORI alert system when we detect increases in opioid overdose cases. Next. Tom, I think this is.
Okay, thank you, Shikhar. And I hope that you get a feel for where the mixed methods research come in. Shikhar shared a nice mix of survey data, also data from qualitative in-depth interviews, right? These are conversations with folks to really hear about the whys and the wherefores and the context that surrounds risk. And then the GIS, the spatial data, help us to look at the geographic distribution of risk across different neighborhoods in and around Lowell. So some of our future collaborative work to combat the opioid crisis, we recognize there's a need for near real-time data-driven responses, and the EMS data are amongst the best that are available for this, because Trinity EMS keeps them well updated, and they have a system together with ODMAP for the feeds to come in regularly. But there's a need for geographically targeted responses. Ongoing public health, EMS, and academic collaboration, we believe, is essential, because folks come in with looking at the problem through different lenses and can bring in different levels of expertise that work well in a complementary fashion. We're in the process currently of thinking about future studies, but I recently did get a different study funded. It's called P2P, or Predict to Prevent. This was funded by the NIH with my colleague, Dr. C.C. Bauer at University of Texas Health. And we're using data from the Massachusetts Department of Public Health, something they call the PhD, or the Public Health Data Warehouse. And this warehouse links more than 25 administrative data sets, including decedent data, including all payers' claims data, right? So any health service that is charged through insurance or paid for is captured in the all payer claims data. It also includes ambulance trip data and Medicaid data, and a whole host of others. And we're employing some sophisticated methods, Bayesian spatiotemporal models, to help to try to forecast, predict where future overdose spikes will happen across the state of Massachusetts in terms of geography and in terms of time. And we'll also be developing some simulation models to assess the effectiveness of individual interventions and combined interventions in communities across Massachusetts. We'll develop data dashboards that would allow people to turn on and off different interventions in their community to see what the impacts would be on future overdose. This is a snapshot of what the Public Health Data Warehouse looks like. You can see all the different databases that are here, including EMS data, Bureau of Substance Addiction Service data, BSAS, HIV, hepatitis C, state police data, and prison data, data from folks who are incarcerated, Mass Health, which is Medicaid here in Massachusetts, Veteran Services. That's a very, very rich data set, really second to none, I would say, in the country. And one of our first papers has focused on small area forecasting. So we're trying to predict where opioid-related mortality takes place. And these are some of the figures in our recently published paper. Each of those lines in the top graphs represent a different zip code across Massachusetts. And the orange lines represent urban communities or zip codes, and the blue lines represent rural zip codes. And you can see that overall, there's this trend of increase over time in fatal overdoses to be expected. That's what we saw in general. But the beauty of these charts is that we can monitor the trends of individual zip codes over time and see if they had worse or better situations. And why is that? And in the maps in the bottom, they're descriptive in orientation, but that's based on predicting where overdoses were anticipated to happen in 2020 based on data from the prior years that we included. And then more recently, we published this paper on opioid-related mortality. And we've looked at the dynamic temporal and spatial trends by drug type. On the left-hand side, we call this a heat map. It's kind of a unique heat map. You're able to look at overdose trends, right? Overdose changes in overdose rates over time from 2005 to 2001 on the x-axis. On the y-axis, we have age on the left-hand side, right? So the higher you see the red or yellow going, the higher the age group that's impacted over time. And on the right-hand side, it's the fatal overdose risk. So when you see the yellows, the oranges, and the red blotches, it's where the rates are particularly high, well above the state and national average. And through this, we're able to see differences across racial and ethnic groups. We noticed that in the Black African-American community, for instance, that there was kind of this bimodal age risk, people in their 40s and people in their 60s approaching 70 being at accelerated risk for overdose related to synthetic opioids. Now, we've done this for all, for males, females, white, Black, Hispanic, urban, rural communities across the top. And the different rows represent the different types of substances that were found to be associated with the overdose risk. From prescription opioids, you don't see a lot of red anymore, except for recent years, and particularly in rural communities on the upper right-hand side. Then with heroin, synthetic opioids, right, which is where fentanyl has come into the mix in recent years, particularly young men, white men, but also within communities of color and in rural communities. And then stimulants. And this is the fourth wave of the opioid crisis. And we see that within the Black community, for instance, that the trends, the red spots, like the areas of highest rates, are almost identical for people using stimulants versus synthetic opioids. And I think this speaks to the fourth wave of the opioid crisis, where a lot of even stimulants are adulterated or tainted with fentanyl. We also look at overdose hotspots over time, so clustering. And if you just look across the top, you see there's 3 different timeframes: 2005 to 11, 2012 to 15, 2016 to 21. And looking at different drugs that were associated with overdose again, and where in the state where there are significant clusters. So I won't go through all of these, but I'll just highlight on the upper row here that we looked at prescription opioid overdose related clusters over time. And they largely were growing in Western Massachusetts, which is a more rural community, maybe where prescription opioids are more prominent for folks who have more pain as they grow older. I can relate, having had a hip replacement last summer. And then stimulants on the lower line, where there haven't been a lot, but they have started to increase, particularly in some of the areas in southeastern Massachusetts. A lot of the lines are blocking Boston, but we're starting to see increases in methamphetamine-related overdose there. So to recap our overall presentation, we've talked about the opioid crisis in Lowell, Massachusetts, as well as other places. We talked about Lowell peers and gave you some background on our unique collaboration between academic, public health, and EMS experts. And we presented a mix of data, right? Some mixed methods approaches, both in the geospatial analyses and mapping, in the qualitative data that Shikhar presented, as well as some of the survey data that we've been able to collect of late to help put our finger on the pulse of risk during the past year. We have our ongoing collaboration for the Stop OD Lowell project, as well as the Predict to Prevent work. We really appreciate all of your interest, all your questions. We've answered some of them in the chat. I'm in the process of responding to Mitchell's question, so I'll finish that. Actually, let me say it out loud. Mitchell, you said, do you think the increase in overdose for people who have been in recovery has to do with abstinence-only treatment models, not promoting harm reduction strategies? That certainly is a part of the issue. And the example I was going to put that we hear about quite a bit in some of the qualitative work we do in local communities, but also in jails across Massachusetts for another study, is that folks who are on medications for opioid use disorder, methadone, for instance, buprenorphine, they're often frowned upon when they go to a 12-step meeting, a Narcotics Anonymous meeting. And what does that mean for people when they go into a place, like they're on the medications? That's great. They're evidence-based, proven treatments. But if they're also seeking support, right? Medication alone is not enough for some people. There's no one size fits all to harm reduction and to treatment. And having support groups can be also helpful. But when people go into a 12-step meeting, if there's an abstinence only belief, and in some 12-step meetings, this is what people have told us they have heard in their own experience, they're looked at as, well, you're substituting one drug for another. Instead of looking at it like when a diabetic needs insulin every day to avoid the negative effects of diabetes, when somebody's on medication for opioid use disorder, it's a medication to reduce and eliminate risks related to overdose and related to other drug-related health outcomes. So that's certainly part of the challenge, Barry. So thanks for the question. Barry also mentions that he goes to Harm Reduction Works meetings, which are online, scripted harm reduction recovery support. That's great. Are there other questions we haven't answered thus far? Keep them coming. Put them in the QA, put them in the chat. John Seeker, is there anything else you wanted to add in closing, or things that have come up in the questions that you want to respond to?
No, I've just been scrolling the comments, and I'll put it in the chat.
I'm clicking on the link that Barry's put into the chat. That's great. So Harm Reduction Works, they have a meeting calendar. I'll just share my screen because we can do that. Here it is. So this is what Barry's included. This is Harm Reduction Works. So they're meeting resources. I guess they have a Facebook group, news coverage. So it could be of interest to a number of folks. There's a question here from Barry's, and it's similar to a question that somebody asked previously about whether or not Lowell works with the Massachusetts Drug Supply Data Stream, or MADS. This is a program that's led by our colleague, Dr. Tracy Green. And I will say that Shekhar and I collaborate with Tracy and the Rapid Assessment of Community Knowledge team. Really not so far. There's interest among harm reduction experts, including the Life Connection Center and some other harm reduction agencies in Lowell, but city and police departments have not yet allowed drug checking. Hopefully soon. Drug checking has really grown in interest and in benefits. We've helped to evaluate, and hopefully this paper will soon be published, we've helped to evaluate the experiences qualitatively of participants who have gone to drug checking programs within a harm reduction agency within New England. And it's really interesting how drug checking, one, helps somebody to understand what it is they're actually putting into their body, and how that might be different from what they thought they were buying. And then two, from a harm reduction perspective, it opens up another whole opportunity for conversation. And some of the folks that we've talked to who offer drug checking in harm reduction settings say that, oftentimes people want to come in, they want to drop off their dirty syringes, they want to obtain sterile syringes and head out the door. When we do drug checking, it takes a little bit of time. And when we present the results to people, oftentimes that leads to a larger conversation. Like, maybe you should talk to your dealer about this, that, what do they know that's actually what's in the supply? Sometimes dealers were coming in to test their specimens as well, because they don't always know what the cuts are. And so this type of conversation around drug checking often leads to another whole level of harm reduction, when folks could better understand the uncertainty of the drug supply and better understand the need for overdose prevention with naloxone on hand to not use alone, so that if somebody does fall out, that there's somebody else there who can rescue them with naloxone. Call EMS, call emergency responders if needed, and so on. So it's a great question. Lowell's got some work to do in terms of drug checking. There's a lot of interest, but the door hasn't been opened on the city level to make it possible so far. Other questions? I see there was one here, again by Barry's. This, as a participant in the START stimulant treatment and recovery team at BMC, I know that there were at least 6 opioid-related overdoses for folks who only use stimulants. Yeah, we see this more and more. Barry's mentioned it's shocking. Unfortunately, we're seeing it more and more, and that's why there's actually discussion of the 4th wave of the opioid crisis. Even in rural communities, I'm part of a network of researchers that are funded by the NIH, the CDC, and SAMHSA to understand the rural opioid epidemic. And we're doing work in New Hampshire, Vermont, and we've done work in Western Massachusetts and rural communities along the I-91 corridor along the Connecticut River Valley between Massachusetts, Vermont, and New Hampshire. And you know, we're working with folks in Appalachia. There's other study teams in Illinois and Vermont, Illinois and Wisconsin and Oregon. And in many of the sites, New England there's been less methamphetamine, but it is starting to rear its head, increasingly in places like Boston and, like John said, increasingly in Lowell. So it's a major concern, and in some places a particularly challenging concern, and it seems to be growing.
There is an additional question in the Q&A.
Got it. I'll read it out loud, and then maybe Shika or John might want to respond. So, as someone with lived experience working in harm reduction outreach and without much formal education in the field of public health, what are some ways I can foster collaborative rapport with agencies like EMS? I get data from them, but would love for the experiences we see in the field to carry more weight when organizations are deciding which initiatives to prioritize and how to best carry them out. There is forward momentum in this area, but oftentimes our voices are not listened to. John, would you like to respond?
Yeah. So, how do you how do you form a better relationship with EMS? Like, you kind of cut out in the middle.
Yeah. Oh, I'm sorry. Yeah.
That's okay. I think it's on my end. It's tough right now for EMS specifically. We are, as most industries or things in America right now, the staffing is difficult, right? There aren't nearly enough ambulances for the work. As soon as this meeting's over, I have calls pending for me. I'm going to be on an ambulance in 13 minutes, you know. I would say if you can get somebody to sit down and just talk face to face, you know, that's really where this all started. From all of the things that Tom and Shaka talked about was, you know, stem from Tom and I were at an original meeting. We hadn't really met before. Tom came up to me, introduced himself, had a cup of coffee. If I had known, I would have ran away. But, you know, honestly, that's how the relationship that we had with this whole program was, just having a cup of coffee at a meeting 5 years ago.
Yeah, I agree with John. Like, so I've been here at the Tufts School of Medicine for 10 years. It'll be 10 years on August 1st. And in my first few years, I really got out to the communities regularly and really sought possibilities for collaboration. And sometimes it was just happenstance that John and I happened to be in the same meeting at the same time, had similar interests. It was a presentation about issues related to the opioid crisis in Lowell. So we were both drawn to that. I was this morning at a event. It was the Massachusetts Public Health Association event. It was an awards ceremony. Shikar and I were there, and a couple people from Worcester Department of Public Health and from the Massachusetts Department of Public Health were honored for their decades of work really in this area. And I was happy and proud to know, and I met those folks when I first started working here, and they helped connect me to other people. In your instance, in this particular example, right, you're doing harm reduction work in a local community. You want to be able to interact with EMS folks. If you can find people like John in your local community, I would encourage you to reach out to them. John he sits on different advisory boards. He's an expert that presents to the opioid task force in Lowell, which the mayor is oftentimes present at. There are other harm reduction folks around the table. And John's presenting data in those areas that can inform policy. If you're there or a meeting like that in your local community, and you can share some of the experiences that you're seeing and perhaps documenting could be even better, right? To systematically show this is what we're seeing, that can sometimes inform policy and changes. I suspect if you were in Lowell and you reached out to John, he would be open to having a cup of coffee with you and learning about what you're doing. And he might be able to connect you to some other folks, or he might be able to encourage you to head to some of the meetings he's at, because these are places where policymakers are often present. Seeker and I are soon going to present at the district attorney, the Middlesex County District Attorney's opioid task force meeting. Lowell is within the Middlesex County, and DA Marion Ryan, who's been the DA there for many, many years, started this task force years ago. And I presented on some of our Lowell peers' work probably, 5 or 6 years ago on that. And at the same time, people from the Lowell Community Health Center were presenting on some of the data they were seeing in terms of increased HIV infections amongst their patients. And for me, that was the first time I saw any data that pointed to an outbreak or the signs of a potential outbreak in Lowell. And that led to collaborations. It led to conversations with the press because these data were shocking and concerning. I think you put a response in the chat to let us know more about where you are.
If I could, one other avenue, it could be a little bit more specific now that I've had the time. So if your local EMS agency is fire-based, you could reach out to the town and ask to talk with, it's generally called the EMS coordinator or the EMS chief. That's the one who's specifically kind of my role for them would be, in charge of kind of the whole ambulance world for them. Or if it's a private service like we have here, you could reach out to that agency and ask to talk with either their clinical director or their director of ops. A lot of services may not know, like all the information we present, right? It's a national standard. It's called NEMSIS. Every ambulance service in America, all 34,000 of us, there's a standard dictionary of information we have to get for every single call. They may not know they have it, or they may not know how to get it, but it is there. But to give you a little bit more information, that's where I would start.
And thank you, Marin. Out in Oregon, I've got some collaborators at OHSU and Portland State. Glad to hear that the presentation was instructive. I'll just put up our email addresses one last time in case we can provide any helpful information. Don't hesitate to reach out. And my phone number is there for my office. John's is as well. And if you're struggling to find connections to people with whom you might want to collaborate in your local jurisdiction, reach out to us. We collaborate with a lot of people in a lot of places. John has presented around the world on some of the work that he's done related to EMS as it relates to the opioid crisis and the data that they're able to capture and share.
Well, thank you so much. It's incredible the work that you're doing and really this insightful presentation and your willingness to share your information to help others find those collaborations. So we really thank you for your presentation and your time. We thank everyone for participating. Ashley has added the link to the evaluation. So again, even if you're not seeking credit, we will love your feedback. And if you are seeking credit, you need to complete the evaluation to indicate which CE credit you're looking for, and you will get your certification certificate, in 2 to 3 weeks. Ashley also included we hope that you would join us for the next session in our series, which will be in July, on July 14th, and there's more information there. If you have any questions, feel free to reach out to me at elazo@nahu.org. We thank you again, everyone, for joining us this Friday, and we look forward to your participation in our next session. Everyone have a great day. Thank you.
Thank you, everyone.